Good evening. I'd like to welcome our live audience and those of you joining us on Facebook Live or watching via webcast to tonight's Cancer Smart discussion on new advances in thyroid cancer treatments. I'm NBC News Chief Environmental Affairs Correspondent Ann Thompson, and I will be your moderator for this evening. We've assembled a top-notch panel, all leading experts in their field, who will explain the very latest in thyroid cancer treatment, such as active surveillance, surgery, and radioactive iodine therapy, RAI. In the last 10 minutes of this hour, we will take your questions. For those of you who are watching online, you can send your questions through the comments section on Facebook Live or on Twitter by using the hashtag CancerSmart. Please refrain from asking personal questions. Joining me tonight, Dr. Richard Wong. He is the chief of the Head and Neck Service in the Department of Surgery here at Memorial Sloan Kettering. Dr. Eric Sherman. He is an associate professor in the Head and Neck Division of the Solid Tumor Service at MSK and a medical oncologist. And Dr. R. Michael Tuttle, who is from Kentucky, the clinical director of the Endocrinology Service at MSK. Gentlemen, thank you for being here. First of all, Dr. Wong, let's start at the beginning. How is thyroid cancer diagnosed?
So for many patients, they first may feel a lump in their neck when they're just feeling their own neck, and that might bring attention to it. Sometimes it may be at a routine examination with your physician that your doctor picks it up. For more advanced cases, sometimes it may manifest as a change in your voice or more difficulty swallowing. But interestingly, more recently, more and more thyroid cancer is being detected incidentally, almost by accident. And what typically happens is the patient will get some sort of imaging of their neck for a different reason. Let's say you're in a car accident and you strain your neck and you get an MRI of your neck. Often, the radiologist will note that there's something in the thyroid, and even though that wasn't the purpose of the study, and that will then lead itself to more and more investigation until the thyroid cancer is detected.
So it's almost a hidden cancer in some way.
Yeah, for the small ones, it's almost impossible to palpate them or to feel them, and so they don't present themselves at the very earliest stage. You have to find them almost by accident, by imaging. Whereas the more advanced ones, where you can actually feel them, they've already reached a certain size.
Dr. Tuttle, how many different kinds of thyroid cancer are there?
There are multiple different types of thyroid cancer. Probably the most common one we call papillary thyroid cancer that represents about 80 or 90% of all the thyroid cancer. So when most people say they have thyroid cancer, they're generally talking about that papillary thyroid cancer. But there are several other types, including the more unusual ones like medullary thyroid cancer and anaplastic thyroid cancer. I often say, saying you have thyroid cancer is like saying you have a dog. There's Chihuahuas and there's Rottweilers. You see everything. I quit saying that because people would come in and say, I think mine's a beagle, mine's a whatever. So I gave up with that analogy.
Well, my question is, are medullary and anaplastic thyroid cancers, are those the pit bulls and Rottweilers of thyroid cancer?
That's why I quit using this analogy. So the answer,
you're poor breeds.
The answer is probably yes. Certainly the anaplastics, those are very aggressive. The medullaries can run that whole spectrum. So some of them can be aggressive, but many of them are treated. So there are many different types we recognize, and they help us kind of understand what's the natural history, how it would behave, and sort of how our treatments would play out over time.
Dr. Sherman, how do you manage medullary and anaplastic thyroid cancers?
So for medullary thyroid cancer, often first things to do is do surgery. But the thing about medullary thyroid cancer you always have to remember is that about 20-25% of them are going to be hereditary. And it's extremely important that anyone who has medullary thyroid cancer, even if you're over 60 and you have no family history, that you be checked to make sure you don't have what we call a germline mutation. Or we look in the blood to make sure it's something that you can't inherit to someone else. If you have it, then we could screen children, we could screen siblings, and maybe find if the gene early on, that the gene's there, and maybe avoid having the cancer altogether through like early surgery or early detection. So medullary is extremely important that everyone be considered as the possibility of actually it being hereditary. The beginning treatment, as I said, is surgery, and then after that, we watch. You know, it depends on what's going on with the disease, but even if it's spread to other parts of the body, a lot of times it can be slow growing, and we have to take things one step at a time. We don't rush and panic. We have drugs to treat it, but the first part is actually first watching until we think a person's about to become symptomatic from it. Anaplastic is a very, very different type of cancer. That's going to be a very fast-growing cancer right in the neck area. If you go back, well, still probably today, but even that long ago, this would overcome people quite quickly. And because of the lack of treatment, sometimes we even consider hospice as one of the first things to consider. We are getting a lot better, I think, in treating with anaplastic thyroid cancer. But when we first see it, the thing to do is try to get in control in the neck area, because this is where it's going to cause problems. Usually this can be done with chemo and radiation, but there are some small cases where surgery can be done. And we're still trying to figure out what is the role of, how aggressive you should be with surgery, as different centers are still looking at it. But it is a type of cancer that surgically really can be done. Even when you think you can resect it, the way that it can stick to the different parts of the body, trying to take it out can actually make things worse. And then, first going to be aggressive with chemo radiation is the first part. And then when that's done, then we see sort of what else needs to be done if it's already spread to other parts of the body, which unfortunately it often has. But anaplastic thyroid cancer is something that needs to be taken care of right away. It's not one of those cancers that you want to travel to 30 different spots to take care of it. And we actually have a system set up here that if someone calls in and says they have anaplastic thyroid cancer, they get seen within a week. And other places have also started the exact same thing and have seen that as they see people a lot quicker, there are much better outcomes that end up happening. So the speed in being seen is extremely important for these cases.
Dr. Sherman, thank you. I want to remind our live and virtual audiences to submit your questions. Now let's move on to the reason why we're here, and that is to talk about the overdiagnosis of thyroid cancer. That is something that has really come to light in the last year with one study in particular. Dr. Tuttle, what has led to the overdiagnosis of thyroid cancer?
It's always interesting when you say the word overdiagnosis, half the audience says, what do you mean overdiagnosis? Yeah. If I have cancer, it's diagnosis. What's led to it largely is our technology, and it largely is the ultrasound machine. As Rich was saying, people get CTs, they get MRIs, and we find these little small nodules, and then you have an ultrasound, and now we can biopsy nodules that are really small. So it really has been the widespread use of ultrasound that identified very, very small nodules that we never knew about before. Overdiagnosis means you're diagnosing something that honestly didn't need to be diagnosed. It would have never caused any harm in the lifetime, and so there's no benefit to overdiagnosing it. So it's largely been the ultrasound machine and our ability to biopsy these little small nodules that really has uncovered this huge amount of thyroid cancer in the population.
But anytime anybody hears the words, you have cancer, the worst comes to mind. I mean, you think, okay, now I'm picking out my casket and what are they going to dress me in and all that wonderful thought process. So Dr. Wong, what do you tell people when they are diagnosed with thyroid cancer?
Yeah, so you're absolutely right. The word cancer evokes a lot of fear. And what I think a lot of people don't realize is that cancer is really a spectrum of diseases, from the rapidly aggressive and very rapidly progressive anaplastic that Eric was just talking about to the really tiny papillary cancers that can sit and not change for decades that Mike is talking about. And so when we talk about thyroid cancer, we have to decide first what kind of cancer we're dealing with, what's the size, the stage, and then we risk stratify every patient's tumor. And we make a decision when we meet the patient exactly what is the risk that this is going to progress and cause a problem in their lifetime. Mm-hmm. Many patients come and they need to have their cancers treated. So many people with thyroid cancer need to have an operation. Some may need radioactive iodine. And with good treatment, they can live very fulfilled, normal, happy lives. But for some other patients that have really small, tiny little cancers that Mike is talking about, if we decide that this does not pose a threat, what we're now doing is offering a surveillance option for those people where they may come back at regular intervals to get ultrasounds, and we can monitor them and see how these little tiny cancers progress or fail to progress. And we've been delighted so far in seeing that the vast majority of these little ones, when we select them carefully, do not progress in a significant way.
Dr. Tuttle, what is active surveillance?
Yeah, active surveillance makes it sound like I'm doing something, right?
Yeah.
If I say watchful waiting or if I say observe, you don't feel like I'm doing anything. Active surveillance means I'm paying attention to you. What I'm really doing is nothing. And what we're doing is we do an ultrasound every 6 months for a couple years because they're very, very small and they change very, very slowly over time, the vast majority of the time. So unlike other cancers where sometimes active surveillance means repeat biopsies and repeat MRIs and CTs, for us, because the thyroid cancer lives right behind my thigh in the front of the neck, it's really easy to see with an ultrasound. So we basically do an ultrasound every 6 months for 2 years and then once a year.
Is this a controversial issue within the medical community? And I understand that MSK is a leader in doing active surveillance. So A, is it controversial, and how is MSK a leader?
Yeah, I think it certainly is controversial, but anytime you do something new, it's going to be controversial, and it probably should be, because you don't want the whole medical community swinging towards some new idea. 4 or 5 years ago, when we started this really observation program in an aggressive way, it was controversial, and there were a lot of people that thought it shouldn't be done or it should be done a different way. But based on a lot of literature from Japan and some colleagues over there, it was clear that this would work. It's less controversial now because the new American Thyroid Association guidelines that were published last year now give active surveillance as a viable option.
You've got a paper on active surveillance.
We
is that
do.
correct?
Yeah.
And what have you found?
So we've actually learned a lot from this, and we've learned a lot from the patients as we walk through this journey. The first thing we learned is active surveillance is not for everybody. About half of the people say, "Nice talk, can you get me an appointment with Dr. Wong today? It was great chatting with you. And I know what days he's in clinic, so yes, I can do that." The other half say, "That sounds great, see you in 6 months." So it's not for everybody. But for the right patient, it's been an amazing journey to kind of walk through them. It's been interesting that many times it's not the patient that I have to convince, it's their spouse or their son or their daughter, or in fact their primary care doctor or their GYN doctor. So there's a lot of people that you have to convince this is a good idea.
Well, because, I mean, when you think about it, think about how we've approached cancer for decades now. I mean, it's always, if it's there, get it out. That has changed with prostate cancer in recent years. So Dr. Wong, when you tell somebody, you know, instead of setting up a surgery appointment, come back and see me in 6 months, I mean, how do you have that discussion?
Yeah, so I've seen a real evolution in this. As Mike was saying, when we started about 4 to 5 years ago, there were many patients that really were not interested in this approach. They thought that this didn't make any sense. It's cancer. Why wouldn't you take it out if you can do it safely? And it's really been over the past few years when the message has gotten out and more attention has been drawn to these clinical trials that were done in Japan for over a decade ago that already show that in the Japanese population that a large group of people could be followed very safely with this approach. I find that in particular, older patients or people that have other medical problems or people that are really have a fear of undergoing anesthesia or surgery, this is a very popular program. For some people, they will never choose this, as Mike says, and they'll never want to go for surveillance, so they're looking to get into surgery as soon as possible. And we're never dogmatic about this. I think one thing I'm really proud of is that I think that our team really counsels people really fairly on the subject. And if a patient really feels that this is not right for them, we don't really force it upon them.
So you would, if somebody said, look, I can't live with this, I want surgery, you would operate on it?
Absolutely. And surgery, it remains a very viable, reasonable option for these little lesions. And that's been our standard approach for all these years, and it remains a very good approach. And it's the right answer for many people. Because after the surgery, many people feel like this great weight has been lifted from their shoulders, that they don't have to explain to the other doctors why they're not having it removed. Or if they move to California or Texas, the doctors there don't look at them like they're completely crazy because this approach hasn't been completely widely accepted across the country yet.
It's important to note that there really are options here. And we'll often say that this is not for everybody. There are many tumors we are not willing to watch. So we don't want to give the message that you'd never operate on thyroid cancer. The bigger thyroid cancers we operate on every day and we treat.
That would be anaplastic.
Well, even the papillaries.
Really?
Because papillaries that are bigger than 2 centimeters and have lymph node metastasis and spread outside the thyroid. So we're really talking about, it's actually a large group of people because we're diagnosing them, but small thyroid cancers that appear to be confined to the thyroid. And so if you fall in that group, we'll often say when we start the consultation, we're going to choose between two right answers. One right answer is surgery, one right answer is watching. Now let's spend the next 30 minutes trying to figure out the right answer for you. And when we've done that, the paper that we just sent in has 291 patients we've been following for 2 or 3 years, carefully selected, very willing to do it, and only 11 of those patients has the tumor grown in the last 2 or 3 years. Exactly what the Japanese experienced. Yeah, 11 out of 291.
And of those 11, were those fast-growing cancers?
No,
or
none of them have been fast-growing. So out of the 11 that grew, most of them took at least a year or two before I could even tell they were growing. And to tell you about these patients, out of the 11, only half of them have chosen to go to surgery. Even though their tumors grew a little bit, they grew over 4 or 5 years. And some of them are choosing just not to do surgery right now. It's not a good time in their job or their career, or they just moved to a new job. And they say, can I do surgery again in a year or 2 years? So even though it grew a little bit, because it grew so slowly, much to my surprise, I walked in the room and said, it's a little bigger, do surgery. And they go, nice talk, doc, see you in a year. Because they're really committed to that. So it's been an interesting journey to sort of see how they do. As Rich was saying, many people choose this because they're afraid of surgery or they've had a bad experience with surgery. Other people I find using it as a bridge to a better time. If there's no rush, I can get married this summer. If there's no rush, I can go to my son's bar mitzvah. If there's no rush, I just got a new job, or I'm going to retire in 2 years. I'd rather have it done then. So it takes that pressure out of having to do it right now. So it'll be interesting over the years how many follow with Rich and I for 10 or 15 or 20 years, or how many change their mind at some point in the future. And then the last point is every one of them that changed, we were easily able to treat them. The outcomes were exactly the same. So we were able to cure them just as easily with a surgery when Rich or one of the guys did it 3 or 4 years down the road. And all of them felt like it was a good thing. They got to keep their thyroid for a longer period of time. And when they had to do surgery, they said, okay, I've given it a try. I need the surgery done.
So on the most important issue of all, active surveillance does not change life expectancy.
See, that's the real critical thing. And that really goes to this overdiagnosis, that for us to do this, we had to be 100% convinced we weren't going to miss the boat, that it was perfectly fine to do that surgery years down the road. And like we often do at Memorial, if somebody's done this before us, like the Japanese, we went and visited them. We went over there, and they were kind enough and gracious enough to help us set up our program and be very involved in this. So they are entirely thrilled that we're able to bring this to the United States and have been very active with us. So it wasn't just us thinking up some way to do it on our own. We took advantage of the experts in the world and brought it here and hopefully improved it a little bit.
Well, wasn't in fact this in South Korea where the overdiagnosis was first recognized, because all of a sudden there seemed to be an epidemic of thyroid cancer in South Korea and nobody could figure out why?
Yeah, they instituted a screening policy where everyone would get screened, and they saw a huge spike in the incidence of diagnosis of papillary thyroid cancer. I think it went up 11-fold after they started the program. And when they went back and looked at it, they realized that they were detecting this reservoir of patients that had these little cancers that wasn't bothering them, but now they were detecting them and treating them and managing them. And if you look at what happened in South Korea, even though the incidence went up like 11-fold, the death rate from the thyroid cancer did not change one bit, because these were largely lesions that were not going to impact on survival. The dangerous thyroid cancers, as Mike said in the beginning, they present themselves right up front. You know very quickly when you're dealing with a dangerous cancer. These little tiny ones pose no immediate threat.
And it was really interesting in the Korean experience. They always get a bad rap because they had such a high risk. After a few years, a group of doctors in Korea got together and said, this has to stop. And they wrote a letter that was written in one of their big medical journals that said, this has to stop. And sure enough, the doctors and the patients responded to that. So that increase is going down in Korea now, which was a good response to the medical system there.
Well, next let's talk about risk factors and treatments. First of all, how do you go about creating a treatment plan for a patient?
So here at Memorial, there's no such thing as one size fits all. I mean, that's the antithesis of anything we do. If I take my mom to an oncologist, I want a plan designed for her based on her age and her tumor. And so as Rich mentioned, it's all risk adapted, so that we look at all of the information we have before the surgery and the biopsy reports and the ultrasounds and CTs. And then all the findings, I need to know what Rich found in the operating room, that he has to communicate with me afterwards so that I know that. Pathology reports read by expert pathologists. And with all of that information, you can classify people into high or intermediate and low risk. And so that's how we start the journey. We say, based on the information we have right now, here's your risk of recurrence and here's your risk of dying. And then every time you come back, we modify that. Because every 6 months I have more information. I'm not stuck at my guess 6 months ago. Now I have more blood tests, I have more ultrasound. One of the surgeons at UCLA said it, when he meets a patient for the first time, he says he takes a picture and it's a little bit fuzzy. And then 6 months later, the picture gets a little bit more clear, and then 6 months it gets a little bit more clear. So that's our vision of risk stratification. It's an ongoing active process so that if things aren't going well, we can bring Eric to the team early on. And I don't send folks to him when they're terrible, but we see them moving in that direction. We bring Eric and his guys as part of the team to begin saying, what else, what other parts of the process, what other things do we need to modify as we go forward?
Dr. Wong, what about people who don't have active surveillance as an option?
Yeah, so the standard treatment for thyroid cancer is surgery. Surgery comes in different types. Sometimes we do what's called a total thyroidectomy, where we remove the whole thyroid. In some cases, if the tumor has favorable characteristics, we can remove just half of the thyroid, and that leaves our patients with half of a functional thyroid, which a lot of people enjoy because that still creates thyroid hormone and it can help balance their energy level. In some cases, if the thyroid cancer travels to lymph nodes, we have to remove lymph nodes, and that's called a lymph node dissection, and so those surgeries are a little bit more extensive. In some cases, when the cancer is really advanced, it can erode into adjacent structures. There's a lot of critical things in the neck, including your windpipe, your voice box, arteries and veins and nerves that control your voice. And so these structures we spend a lot of time preserving when we're dealing with advanced or aggressive thyroid cancers.
Eric, when you see somebody who has advanced thyroid cancer, is chemotherapy an option at some point?
So chemotherapy was an option. We've sort of gone away from cytotoxic chemotherapy, so using the old drugs, cisplatin, doxorubicin, that sort of, just cause havoc throughout the whole body. And we've gone through a more targeted therapy. And these things are things that hit things like VEGF, what we call the vascular system, or where the tumors try to grow blood vessels so they can get more oxygen in and spread and try to kill those off so the tumor itself can either be contained or die down. Or there's other targets that are also becoming much more important for us to hit. But we do sometimes will still use chemotherapy with radiation to control things in the neck if surgery can't be done. So just because surgery can't be done in a situation because it'll be too dangerous or too morbid, we have good data now that says you can use radiation with some little bit of chemotherapy and actually get extremely good control rates. And that's very different than the way we thought of things back 10 or 15 years ago, where if you couldn't do surgery, radiation was sort of like, well, we'll give you some radiation, but it's probably not going to work. Now we actually have data showing we can give radiation, we give a little bit of chemo. The chemo is low enough that it really doesn't bother people, or doesn't bother people much. I know Matthew's laughing.
I love oncologist says a little bit of chemo.
Yeah,
a little.
Just a little bit of
doesn't
chemo.
bother anybody.
You barely notice it's there.
You barely notice it.
And we've gotten extremely high control rates at 4 years. And we're about to publish data probably in the near future showing that quality of life is actually excellent. That, you would think giving chemo radiation, you're going to destroy someone's quality of life, and actually it might get better than the baseline. So, we've looked at this very carefully. We've done prospective study with it. We've looked retrospectively, and we have a large experience with it. So there are a lot of options that exist even when surgery can't be done.
May I ask a really dumb question? At the beginning, we talked about something called radioactive iodine treatment. Is that radiation, or is that something different?
So the answer is yes. Next question.
What, that it's dumb? My question is dumb, or it's radioactive iodine treatment is radiation?
Professional. I should have known that. So radioactive iodine is a form of radiation. It's not the form Eric was talking about. When Eric was talking about using radiation for bad stuff in the neck that you can't operate on, that's that external beam radiation that you get once a day for 6 weeks that friends may have had for breast cancer or colon, that kind of stuff. Radioactive iodine is completely different than that. I used to be in the Army, so I call radioactive iodine my heat-seeking missile. It turns out most thyroid cancers, like papillary and follicular, they need iodine to live. They can't tell normal iodine from radioactive iodine. So we can have you swallow what's really a very small dose of radioactive iodine. It'll circulate everywhere in your body, and then the thyroid cancer picks up the radioactive iodine, enough that we can do pictures and see where it is, and then with a little larger dose do treatments. So Dr. Sherman and these guys always talk about targeted therapies like it's something brand new. We've been using radioactive iodine since the 1940s, so it's nice for those guys to do targeted therapies. But the ultimate targeted therapy is radioactive iodine. So a very, very safe, very, very effective medicine that it's not for everybody, but for the types of thyroid cancer based on the histology that it may work on, it's one of our most effective treatments.
And what are those types of thyroid cancer, again, that
So the
RAI would be most
the
effective
easiest
with?
ones to say the ones they're not, and they're
Okay.
not the ones that you'd really want them to work on. The anaplastic that Eric has to deal with, the medullaries don't concentrate radioactive iodine. So it's really the papillary and follicular thyroid cancers. That's particularly good. It kills lymph nodes, it kills lung metastasis from the thyroid cancer. So fortunately, it works in the vast majority of the patients that need it. It often doesn't work as well as we want to, because Eric and his group have done some cool studies where many times we do radioactive iodine and it doesn't hardly work enough. It grabs onto some, and then I'll send them down to you. And what do you do to them? Something nice.
So we actually have discussions. This is sort of where we get to some personalized medicine. And a lot of this is actually stuff done in Jim Fagan's lab at Memorial, where he looked at if you do overstimulation of a certain pathway, we call it MAPK or B-Raf pathway. And basically, if that pathway is overstimulated, which it is in over 70% of papillary thyroid cancers, so not that uncommon, but if it's overstimulated, the receptor that's required to take up iodine and bring in the radioactive iodine into the tumor, that's just not expressed. But if you cut that pathway, you block it, then all of a sudden some of those receptors come back up to the surface, and now tumors that were not able to pick up radioactive iodine or could only pick it up just a little bit, suddenly can pick up a lot. And it doesn't work for everybody, but it does work for some people. So we did a pilot study with this, and about 20 patients. Alan Ho led it, and he gave people a drug called selumetinib. Selumetinib is something called a MEK inhibitor, which is along that pathway. And what he found was that of those 20 patients, 12 of them who couldn't pick up radioactive iodine very well before suddenly could pick it up more. And 8 of them picked it up so much that they were able to get treated again. And we actually saw some extremely great reductions.
Wow.
And so we were able to show in patients who couldn't get iodine anymore, now they could get iodine once again. And the next step, which has already been taking place, is say, well, this is great for advanced tumors. What about these early tumors? Tumors that Rich takes out, but unfortunately they have a high enough risk that they're going to probably come back. And Mike's going to give him some radioactive iodine, but guess what? Just probably not going to work that great in this group of patients. What if we gave that drug at that time, and then with microscopic disease, or disease that you don't see, suddenly allow that to pick up high amounts of radioactive iodine? So Mike and Alan Ho led a gigantic study, international study, where people were randomized after surgery to either get this drug or not get the drug, and then get radioactive iodine. And we're going to find out those results next year. But this is sort of bringing things right from the lab, from Jim Fagan's lab to advanced disease, and now trying to bring up earlier in the course with the hope that we're actually cure even more patients with thyroid cancer by making Mike's smart bomb even smarter.
I want to remind our live and virtual audiences once again to submit your questions. For those of you who are watching online, you can send your questions through the comments section on Facebook Live or on Twitter by using the hashtag CancerSmart. We will be getting to the question and answer section in a few minutes. But first, let's talk about the options for patients when radioactive iodine treatment doesn't work. Dr. Sherman, we know that today there are more personalized medicine efforts than ever before. So if radioactive iodine, even if it's turned into a smart bomb, still doesn't work for you, what are some of the other options available to patients?
So it's a very, very different world than it was 10, 15 years ago. You know, I remember 15 years ago getting a patient, probably from Mike, that, you know, with thyroid cancer, and he's tried the radioactive iodine 300 different ways, and it wasn't working, and he sent the person to me to, unfortunately, basically do best supportive care. Yeah. This is a completely different world, that over the last decade, we have tested many new drugs in advanced thyroid cancer, gone away completely from the cytotoxic chemotherapy to these more targeted therapies. The initial target therapies that we're looking at right now are things that are not specific or individualized or personalized for one person. One is a drug called sorafenib, the other one's a drug called lenvatinib. Sorafenib and lenvatinib are both what we call VEGF TKIs. They sort of kill off the blood vessels that feed into the cancer cells, allowing them to grow and allowing them to spread to other parts of the body. And by doing this, we're able to shrink the tumor and keep it under control for a longer period of time. Each of these drugs have gone through randomized studies and shown that compared to placebo, doing nothing, they're able to let people or keep the disease from progressing for a longer period of time. Sorafenib was the first drug out there that showed this and was able to really increase the median progression-free survival from about 5.5 months to about 10.5 months, which was a good first start. Lenvatinib basically showed amazing results where it was able to go from 3.5 months to 18.5 months. And not only was it able to do that, in about 65% of the cases, lenvatinib was able to shrink the tumor in half or greater. So it makes the tumor smaller. It actually has, in the study, 4 patients actually had what we call a complete response, meaning the tumor shrunk to such a small size that we don't even see it. There's no thyroglobulin. It was, you know, which we have never, ever seen before. So it's just amazing that we have these 2 drugs available. And how we use them is always the question. Lenvatinib can be used in the first-line setting, but actually when you look at it after other people got other VEGF TKIs, it's not like you get one drug. You find that it actually works almost just as well. So you could go from one of these drugs to another drug to another drug, and they work extremely well in taking care of the disease. And you know, they do have some side effects in that they do, because they hit multiple different targets. But at the same time, these are side effects that people tolerate. When people are on these medications, we get them to a dose level where people can do their normal function. If they work full time, we expect that when you're on these drugs, you work full time. They're all pills. You know,
are they pills that you take
at home
a day, once a day, or?
So sorafenib you take twice a day, okay, and lenvatinib you take once a day, and they're easy things to you just take it at home. It's almost like any other prescription, except it's even nicer because they usually bring it right to your doorstep, the pills. But it's like taking your aspirin for your heart disease, or actually it's easier than taking your insulin for diabetes. It's something you take every day, and it keeps the disease in check, and it can keep it in check for quite a while.
And are you taking these for the rest of your life or for a certain period of time?
So usually right now we have it so people do it for the rest of their life. It means when you start them, you keep going on to them as long as, 1, they're working, and 2, people tolerate them. There are groups that are trying to look at the question, do you really need to do that? So in France, they were doing a study where they're trying to actually do it for a shorter period of time and then see if you can give a break in between. And there's both theories why that will work really well and theories why it doesn't work really well. But these are the questions that people are trying to answer right now. People are trying to answer, sometimes is the dose that was used in the studies the right dose for every patient? And sometimes we make those adjustments. But we do those adjustments to get people on a treatment dose that they could tolerate. And like I said, if it's not a dose that you could tolerate, if it's keeping you in bed, if it's keeping you in a wheelchair, it's making you lose way too much weight, then we stop, and we can't do anything to stop it, then we stop it. But usually we can get people to a dose level where they may have some side effects, but they should be functioning fully normally.
And what are, just before we go on, what are those side effects?
So for both of those drugs, the big side effects are things along the vascular pathway, meaning high blood pressure. You might get blood clots. The risk for blood clots are extremely small. Some people, on their hands and feet, it gets red. And it's actually, these are things that we can take care of. You stop the drug, it goes away in a few days, you go to a lower dose of the drug. Like I said, we find a level where it works. And we've used these drugs long enough that at this point, it's actually we actually know how to treat these very easily. It's a very different world when these drugs first came out. I can tell you, when I used these drugs for the first time, like over a decade ago, I was sort of like, almost in wonderment, what am I supposed to do, with these things? And this has completely changed that we know exactly how to do it, how often we have to watch people. And we get to the point that once we get people in the right dose, which takes about a month to 2 months sometimes, there are patients I see like every 3 months. You don't have to see people that often. There's people who live far enough away, I've even gone to every 4 months. So it's something that people can be on for a long time and really tolerate very, very well.
I mean, it's really an important message for people and physicians to hear that there are treatment options now. I spent the first half of my career hiding people from Eric because he might actually give them chemo. And they would stay with me and we would do nothing. And there are still many patients in the United States who are being given that advice. Or their doctors were aware of the early experience with these drugs and we weren't as good at using them. So this message that if you have metastatic disease that's spread somewhere and radioactive iodine is not working, many times just watching is the right thing because it's slow. But there are options, and the oncologists need to know about that. Many of these patients are followed by endocrinologists like me, who in their training were taught there's nothing else to do. So it's important for patients and doctors to go, no, there are options, and find the unusual oncologist like Eric that specializes in thyroid cancer and knows how to use these medicines. So really an important concept that there are treatment options now for essentially all of our thyroid cancer patients.
And Dr. Sherman, what's coming down the pike?
So down the pike, there's actually really exciting things coming around. So as we talked about before, when we're trying to make tumors more sensitive to radioactive iodine, these tumors have mutations. And the nice thing about these mutations in thyroid cancer is that we actually have drugs that can hit those mutations. So while these VEGF tyrosine kinase inhibitors, things like sorafenib and lenvatinib, can be used for basically all thyroid cancers, we can actually find very targeted therapies that may hit a certain mutation, limit the toxicities, and get extremely good results that can last a while and be an additional way of trying to treat it. The most common mutation we see in thyroid cancer is something called a B-Raf mutation. It's seen early on around 40%, but probably in my population more around 45% of papillary thyroid cancers will have this B-Raf mutation. And this is the same mutation that they see in melanoma. And in melanoma, years ago, they've done studies with these B-Raf inhibitors and showed extremely high response rates. We've done the same studies in thyroid cancer. We get still very good response rates, not as high as what we saw in melanoma, but still very good and keeps the disease under control for a while. And what's making this world even more exciting is that we're trying to figure out better ways of using these B-Raf inhibitors. Jim Fagan's lab here has looked at ways that thyroid cancers may become resistant early on to these inhibitors. And by adding a second drug, we may get much higher responses. There are also ways to try to better block the pathway. So maybe using other drugs in addition to B-Raf along that pathway may do a better job. And a lot of this stuff is actually probably going to come out, I could tell you, in the next few months. Wow. These studies are really being presented. And this is an extremely exciting time. But besides the most common mutation, there are uncommon mutations that there are also great drugs that hit. There are occasionally something called ALK mutations or NTERK translocations. And we have these drugs either already in clinic for other cancers or in trials that target those mutations very well. And you can get very good responses that can last a while if the tumor has those mutations. And there's even TSC1, TSC2 mutations. where you can get extremely long responses with mTOR inhibitors. So these are all drugs that are out there, either in clinical trials or actually approved for other indications that you can use to try to treat these cancers. The thing or the trick that you have to know first is, do these mutations exist?
Right.
And that's one of the main pushes that have been going on in research at Memorial Sloan Kettering, where basically every patient with metastatic thyroid cancer that's going to need treatment in the future, we type the tumor and we look for all these different mutations. It's a test called IMPACT. We look for over 400 mutations in each of these cancers. We find mutations that you might not even expect to see in this cancer every so often, and we find a drug that actually hits that mutation. But we also find these more common mutations, so we know how to try to treat these how to treat different patients individually with sometimes drugs that can really hit a very small target instead of these VEGF agents, and sometimes with, like I said, a lot less side effects, and just gives us additional treatment options for them.
Dr. Wong, given where the thyroid is, right here, is this?
Yeah.
Am I sort of in the general direction? Somebody in my business would worry about what is surgery going to do to my voice.
Yeah.
So where is voice preservation?
Yeah, so that's one of the key goals of surgery is to remove the thyroid and the cancer completely and preserve everything else and leave our patients no different after the surgery except for a very small and thin scar line that heals beautifully. But the nerves that control your voice run right behind the thyroid, and they are at risk with surgery or from being affected by the cancer itself. And so we use a variety of techniques. Most of them are just surgical techniques to identify and preserve the nerve, but we also use technology. We have a machine called the Recurrent Laryngeal Nerve Monitor, which is it's been around for a while now, maybe like a decade, and it enables us to monitor the function of the nerve during surgery, and it helps us to find and preserve these nerves.
So do those nerves, would those affect the quality of my voice? I mean, could I come out sounding like Brenda Vaccaro or Pee Wee Herman after the surgery?
Not so dramatic, but it's possible your voice could sound raspy and weak and breathy as a result of the surgery. So the good news, though, is that that's very uncommon and that we've gotten really good at saving these nerves. I quote the risk of permanent vocal cord paralysis from the surgery as being less than 1%, and the risk of a transient vocal cord paresis or a transient disturbance might be in the order of 3% possibly. So we've done really well on this one. The patients that are at higher risk for a voice problem, we can predict those people in advance when we see that they have big tumors or aggressive tumors, and those people are counseled differently. Sometimes we have to do these more extensive surgeries just to get the cancer out, and in those situations, if the voice is affected, we can restore the voice secondarily with other kinds of procedures after the surgery is done.
Okay. So I think now we'll go to questions from our audience, and why don't we start with our Facebook Live questions. Amy?
Yes, hello. Good evening, everyone. We do have a few questions for the docs on the panel. One comes from Barbara on Facebook. She asks, at what point would you recommend having radioactive iodine treatment?
Yeah, that's a great question. So in many centers, almost everybody with papillary cancer gets radioactive iodine. It's almost like automatic, surgery and radioactive iodine, and we don't here. So we look at what happened in the surgery, we look at the pathology report. Usually we'll wait about 6 weeks after surgery and measure a really good tumor marker called thyroglobulin. It's only made one place in your body, and if Rich has taken the entire thyroid out, that marker should be nice and low. It's quite controversial. Even among the guidelines, there are many people that we say should selectively be used. So the ones that are easy is people that we know the thyroid cancer is spread somewhere else in the body, or they had big lymph nodes or great big tumors like Rich was talking about. That's almost automatic yes. The little teeny tiny ones that we don't even want to operate on, that'd be an automatic no. And most other people are in the middle where we have to sit down and talk about the risk and benefits for that individual person.
I think as Melissa and the team go around to collect questions from those of you here in the audience, you'll see them circulating through. Just related to Barbara's question, do you find that patients are wary of radioactive iodine therapy? Do they ask a lot about risk? Are they worried about the long term?
So it can go both ways. As Ann was saying before, we all know once you have cancer, you should do everything. You should have surgery, and you should have radioactive iodine, and get whatever a little chemo is from air. You should just do everything. And so there are some people that just want everything done. There are other people that say, no, this radiation sounds scary or dangerous. Tell me about it, because I've got kids at home and I've got families. Because unlike the radiation that Eric uses, that's just radiation from the outside, when you swallow radioactive iodine, you're going to carry that home. It circulates in your body for a couple days. So you actually meet with our radiation safety docs, our radiation physicists, so you'll leave with a very strict written protocol that basically says stay arm's length from everybody for a couple days. And over a couple days, you basically empty the radioactive iodine out of your body, maybe a little bit longer for kids. So yeah, there is a definite discussion when we treat with radioactive iodine about radiation safety issues.
Another from Facebook comes from Jennifer. She says, my thyroid was removed and I had my RAI treatment last year. She's worried about her children. Will they need to be tested for risk for thyroid cancer in their future? What do we know about that?
Yeah, it's a great question. So it comes up usually at the end of every visit or the second visit once they begin to sort of, the short answer is no. In the typical papillary thyroid cancers, we don't expect any genetic testing. It's generally not going to be hereditary. Eric made the case before that the medullary cancer is a whole different ballpark. So about 25% of the medullary cancers will have a genetic issue that needs to be dealt with. That being said, there's about 2 or 3% of patients that have multiple family members with papillary thyroid cancer, like 4 or 5 or 6. We don't understand the genetics of it. It skips generations. So it's a very, very unusual group that we would say do any kind of screening for. So as a general rule, when the young moms ask me that, I tell them their kids are at no higher risk than their neighbor is from having thyroid cancer.
We have a question from our audience here. Does having hypothyroidism make you more susceptible to thyroid cancer?
Oh, that's a great, I'm on a roll. That's a great question. So the answer is maybe. Where this comes from is there's some studies that say if you have a thyroid nodule and you're a little bit hypothyroid, that nodule's a little bit more likely to be thyroid cancer. Now, I don't think that the hypothyroid caused thyroid cancer, but if you had thyroid cancer and you're hypothyroid, it can stimulate it to grow a little bit. Okay. So we don't think hypothyroidism causes cancer. If you look at studies in people that had hypothyroidism, they're a little bit more likely to be diagnosed, but guess who they're seeing? Endocrinologists, and they're getting ultrasounds. So.
Well, my question would then be, is hypothyroidism an indicator of thyroid cancer?
Yeah, no.
Yep.
So hypothyroidism is an indicator of hypothyroidism. Okay. And it's very, very common in people in their 50s and 60s. It just happens all the time. So we don't want people freaked out about hypothyroidism. But there's some studies that say there may be a little slight link in there somewhere.
What about hyper?
So the question is, what about hyperthyroidism? Yep, so the hyperthyroidism is the same way. There's no association between hyperthyroidism. So the function of the thyroid, which has to do with hypo and hypo is low and hyper is high, you have functional problems that are completely distinct from the structural problems, and the cancer is the nodules and the structural problems.
Okay. Is there any link between breast cancer and thyroid cancer?
I'm being shy here. So if there's no answer, I get to answer the ones that have no answer. If there's an answer, these two ring in 5 seconds. Yeah. So here's my next fake answer. So the real answer is no. But again, if you look in big tumor registries and say, in people that have thyroid cancer, what other cancer pops up? It's breast cancer. But thyroid cancer is more common in women. Breasts are more common in women. And so some women with thyroid cancer are going to have breast cancer. And so there's been many studies that looked at the thyroid cancer can be diagnosed before or after. So again, it's probably a screening thing. Mm-hmm. There are a few rare genetic events where you can get thyroid cancer with breast and other things. But by and large, it's just the 2 cancers that happen in 30-year-old women.
Is there any cancer that is associated with thyroid cancer? I mean, if you get thyroid cancer, you are more likely to get cancer
Yeah, the short
X?
answer is no. That, in fact, in the guidelines, we say if you had thyroid cancer, don't let your doctor do any extra screening. Get your mammograms at the right age, get your colonoscopy at the right age, do all the normal screening. So with thyroid cancer running by itself, no, there's no other genetic testing, there's no other screening we want anybody to do.
Amy, anything else from Facebook
Well,
Live?
no, but Rich had talked earlier about voice preservation, and so, as the surgeon here, talk a little bit about swallowing and what happens after, and sort of the rehab that might or might not be part and parcel of the treatment regimen.
Yeah, so most people do really well with swallowing. When we do the thyroid surgery, we don't generally disrupt the swallowing mechanism. After the surgery, people have a little bit of trouble with their first meal, but then usually by the second and third and fourth meal, they're eating pretty much everything. There's a few minority of people out there that after they're all healed, they say, oh, it's a little bit more hard to swallow. And I always wonder if that's related to how they healed or scar tissue or some other intangibles from surgery. And certainly the more extensive surgeries where we have to work around the esophagus, that could be a little bit more likely. But most of the time, people swallow pretty normally after the surgery. And that's why when they come back and they've gained weight, I can blame it all on them being hypothyroid because Mike didn't give them enough hormone rather than them being unable to swallow.
Unnecessary. If he would have left the thyroid in there to begin with, we wouldn't have this problem. That's right.
Is a cyst on the thyroid indicative of more dire things to come?
No, if anything, cyst is less worrisome. So there are not a lot of cysts in the thyroid, but if there's cysts, which is just a collection of fluid within the thyroid, by and large, those are benign, and we just watch those.
And remember, thyroid nodules are extremely common to the point where we consider them normal. By the time you reach the age of 60, you already have a 50% chance of having one by ultrasound. So just because you're found to have a thyroid nodule does not mean that you're abnormal or there's something wrong with you. That's expected statistically by the time you hit 60.
That's one of the pleasures of a long life.
That's right.
Would a decision on active surveillance be influenced by any other factors, such as skin cancer or any other cancers that you've had in the past? If you have a past history of cancer, does that make active surveillance not something you should do?
From a biological standpoint, no. From a psychological standpoint, sometimes.
Yeah.
And it can go either way. I've got patients that are being followed with active surveillance for prostate cancer, and somebody finds thyroid cancer. Well, of course they're going to watch. I've had other people that just got through their breast cancer, and they want this behind them, and daggone it, there's a thyroid cancer, and I want this out of my neck. So from a biologic standpoint, no, I'm perfectly comfortable watching you, and we watch many people, as you can imagine, that we find thyroid cancers as part of the treatment for their other cancers with our scanning and stuff. But I do sit down and try to talk to them, understand sort of their psychology, and say we can go both ways. And are you more inclined to do something? Are you more inclined to watch? So they will often have a little bit of a different perspective on this than somebody that this is their very first cancer.
One of our surgeons, Ben Roman, is doing a study where he's investigating now what goes into patients' decisions about whether to join active surveillance or not. And he's giving questionnaires to patients and asking them what matters to you and what went into your decision. He's then going to interrogate them down the road and see if they have any regret or any conflict over their decisions and whether they were happy with their decision. Simultaneously, he's going to look at how we as doctors counsel our patients. And he's going to videotape Mike and me. Probably not Eric, because we're not in that same arena.
We'll show you the videotapes. They'll be cool.
Right.
We'll show them to you.
But he's going to compare how, as surgeons, we counsel our patients and to see what are the things that we're telling them that may be impactful on whether they choose to enter or not enter. If I counsel very aggressively in favor of it, obviously that may help them feel more comfortable. But these are the intangibles that we're trying to learn about.
Well, and I was just thinking that as a cancer patient and somebody says, do active surveillance, and well, that's my doctor. Of course he's going to say that. But I've got this, psychological and emotional burden. Does MSK offer any other kind of counseling outside of the doctor's office with a third party that says, let's just walk through what your issues are here?
So sure. So part of this decision, because you'll hear us always kind of change, say from a biology standpoint, perfectly fine to watch. But the trouble is not all biology. There's a lot of stuff about the patient that we need to understand. So we really rely on shared decision making. I mean, I'm going to tell you what I think you should do, but you'll help me understand that. And so part of that is if you're going to follow with active surveillance, you're probably going to see both me and a surgeon, where you discuss the options of surgeon with the surgery, so I don't slant that too much. We've got social workers. I've got several of my patients that are walking this journey that are more than happy for me to give their name outs and emails so they can tell other people what walking through this journey is like. So yeah, it's a lot more than just one person trying to inform the patient. And sometimes it's easy because people know they want to watch and they just come to ask me for permission, or they want surgery and they just go get their surgery. But the ones that don't, we often send back and forth between the two of us and say, you don't have to make a decision today. Go see Dr. Wong, do an ultrasound here at Memorial. Let's talk about this again. If you're having a hard time, there's no hurry. Think about it for a month. Come back and see me. The nice part about this is we don't have to rush and make a decision today. And in fact, many of my people that choose active surveillance actually just choose not to make a decision today. I don't want to do this, and I say, that's fine. You want to come back and do an ultrasound in 3 months or 6 months, and let's talk about it again. So we're not making the decision that we would never do surgery. We're making the decision it's not critical right now, and you have some more time to think about it. I tell them, if you change your mind in a week, call me, call Dr. Wong. He can take it out in 15 minutes. It's no big deal. But if you don't make that decision, you've got an ultrasound in 3 or 4 months, and we'll talk about it again. So it's really an iterative process rather than a yes, I'm going to be treated, or no, I'm not going to be treated.
Well, we are out of time, so if I were to wrap up, and correct me if I'm wrong, the good news about thyroid cancer is, A, it's been overdiagnosed because we have better technology. But if they do find thyroid cancer, active surveillance is certainly an option for those small cancers. If you have metastatic cancer, there are drugs out there that are going to help extend your life, and it doesn't mean you have to go to the hospital every day. You can take these pills at home. And if Dr. Wong has to take it out, he's going to leave a nice little slit and not make you sound like Brenda Vaccaro or Pee Wee Herman. That's it for this evening's Cancer Smart discussion. Thank you to all our panelists, Dr. Wong, Dr. Sherman, and Dr. Tuttle. And thank all of you for joining us tonight. And I would like to thank everybody here in the live audience for asking such great questions, and all of you at home for tuning in. Please be sure to visit www.cancersmart.org to learn about upcoming programs like our Cancer Smart discussion on breast reconstruction this summer. You can also find great resources and support on our Facebook and Twitter pages, which have the @ sign, and it's Sloan_Kettering. Good night.